Now coming to tubular and interstitial diseases. Usually they are taken together. So just a small revision about the tubules. So I told you we have the proximal tubules, the loop of Henle. Loop of Henle has the thin descending limb, thick ascending limb, distal convoluted tubule, the cortical collecting duct and the medullary collecting duct. So each of the tubules has a particular function. Proximal tubule is easy to understand, like most of the electrolytes are reabsorbed here. Most of the, like 65% of the water and 65% of the electrolytes are reabsorbed here. Okay, so from the lumen you can see sodium is reabsorbed, phosphate is reabsorbed, glucose is reabsorbed, amino acids are reabsorbed. Plus bicarb is reabsorbed here, that you have to remember, because there's a disease called as renal tubular acidosis. Renal tubular acidosis is also a disease of the tubules. It is of three types: type 1, type 2. Previously there was a type 3, it is not clinically important, and type 4. Type 1 is called as distal renal tubular acidosis. I told you any problem in the tubules will cause problems with the electrolytes. There can be problems with the bicarbonate, so there can be acidosis. I'll note it down first. Electrolyte abnormality, like we discussed about glomerular diseases causing hematuria, proteinuria, edema and hypertension. Tubular diseases cause electrolyte abnormalities, they cause acidosis. Anemia is common because erythropoietin is produced by the tubules. Vitamin D and calcium homeostasis is affected, so there can be hypovitaminosis D. And there can be changes in the calcium and phosphate. When calcium and phosphate is affected, we know very well that secondary hyperparathyroidism occurs. That is called as osteitis fibrosa cystica, or the Brown's tumor, or the von Reckling-Orson's disease. So these are the common features of tubular diseases. So type 1 I told, distal RTA. The function of the distal tubule is to secrete H+. So secretion of H+ is affected, so there will be acidosis in the blood. This is very severe. It occurs in the pediatric age. This acidosis is very severe. When acidosis is severe, there will be calcium and phosphate changes, so usually it affects the growth. So treatment is bicarb supplementation. Type 2 is a problem with the proximal tubules. Type 2 RTA is a problem with the proximal tubules. I told you proximal tubule, the function is bicarb reabsorption. So this bicarb reabsorption is affected. Here the disease is mild because whatever acidosis occurs due to proximal tubular dysfunction, the distal tubules compensate for it. So even though bicarb is not reabsorbed in the proximal tubule, the distal tubules compensate by secreting H+, so this will be mild. This occurs in adults. Only mild acidosis here. Type 4 is usually drug induced. Here there will be hyperkalemia, hyperkalemic metabolic acidosis. Okay. Since proximal tubule reabsorb most of the electrolytes, many diseases like as Fanconi syndrome, etc., can involve the proximal tubules. Now, what is the important channel in thick ascending limb of loop of Henle? It is NKCC2 channel, sodium potassium 2-chloride channel. Two important points which you must remember about this channel is loop diuretics act on this channel. One disease affects this channel, which is Bartter syndrome. Causing distal convoluted tubule, we have another channel called as NCC, sodium chloride cotransporter. This is important again for two reasons, because thiazide diuretics act on this channel, and this channel is affected in Gentleman syndrome. So you can put a table. I use the mnemonic boyfriend got time. Bartter syndrome is similar to furosemide. So the features of Bartter syndrome or loop diuretic, that is furosemide, both are same. The features of Gitelman syndrome and thiazide diuretic, both are same. So what channels affected in Bartter syndrome? NKCC2 channel in the thick ascending limb of loop of Henle. What channel is affected in Gitelman syndrome? It is the sodium chloride co-transporter in the distal convoluted tubule. Remember, when this channel is affected, most of the electrolytes are not absorbed. So there will be hyponatremia, hypokalemia, hypomagnesemia, this is common for both. So hyponatremia, hypokalemia, hypomagnesemia is common. But remember, only one difference is loop diuretic cause excretion of calcium. So there will be hypercalciuria in loop diuretic. Whereas in thiazide diuretic there will be hypocalciuria. So thiazide diuretic does not excrete calcium. That is the reason why thiazide diuretics are given as a treatment in recurrent calcium stones, because calcium is not at all excreted when thiazide is given. There will be hypocalciuria with thiazide diuretic. Whereas loop diuretics are contraindicated in calcium stones because calcium is excreted in the kidney, causing renal stone, calcium stone formation. Since there is hypercalciuria in loop diuretic, there will be hypocalcemia, low calcium in the blood. Since there is hypocalciuria in thiazide diuretic, there will be hypercalcemia in the blood. It's not actually hypercalcemia, like calcium will be normal in the blood. So these are the differences between Bartter's and Gitelman syndrome. So that is why we must know about thick ascending limb and distal convoluted tubule. Cortical and medullary collecting duct is very important because we have an important channel called as ENaC, epithelial sodium channel, ENaC. This sodium channel is activated upon by aldosterone acting on the aldosterone receptors in the cortical collecting duct. Cortical collecting duct has two types of cells, principal cells and intercalated cells. So principal cells have aldosterone receptor. So aldosterone acting on the receptor stimulates ENaC, causing sodium reabsorption. So the drug which inhibits this is amiloride. The activating mutation for this will be Liddle syndrome. It is not inhibiting mutation. The activating mutation for this will be Liddle syndrome. So when there is activating mutation of ENaC, what happens? There will be increased sodium absorption and there will be hypertension. What drug can inhibit this channel? So I told amiloride inhibits the ENaC channel directly. Another way by which this process can be inhibited is by doing aldosterone antagonist or mineralocorticoid receptor antagonist, that is spironolactone or eplerenone. So two categories of drugs are used to inhibit this process. One, by giving aldosterone antagonists like spironolactone or eplerenone, which inhibits the mineralocorticoid receptor, or by giving epithelial sodium channel antagonists like amiloride. Activating mutation of this is called as Liddle syndrome, which causes hypernatremia and hypertension. Then the type A intercalated cells are important because of proton excretion, H plus excretion. So pathology of this will cause renal tubular acidosis type 1, that is the distal RTA. Now we should also think about vasopressin. So cortical collecting duct, we have medullary collecting duct. The medullary collecting duct has vasopressin. Vasopressin or adrenal antidiuretic hormone will act on this vasopressin receptor. This is the V2 receptor, to cause expression of a protein called as aquaporin in the luminal membrane. So this protein is called as aquaporin 4. This aquaporin 4 expression causes more of water reabsorption from the lumen into the blood. Right? So both sodium balance and water balance is dealt with the collecting duct. That is why this part is very, very important. So sodium control is maintained by mineralocorticoids like aldosterone acting on the mineralocorticoid receptor in the cortical collecting duct, activating the ENaC channel, taking in sodium. Water balance is maintained by antidiuretic hormone acting on the V2 receptor in the medullary collecting duct, reabsorbing water through the aquaporin 4 channels. Remember, problems with water regulation lead to sodium changes. What are the sodium changes which we know? Hyponatremia or hypernatremia. I'll make it simple. Hyponatremia can occur with excess antidiuretic hormone production, syndrome of inappropriate excess antidiuretic hormone. I told you ADH controls water regulation only. So when water is absorbed more, right? When water is absorbed more, sodium gets diluted, right? So sodium changes are actually due to problems with water regulation or vasopressin problem or ADH problem. So SAADH causes excess water reabsorption and hyponatremia. On the contrary, deficiency of ADH causes diabetes insipidus, which causes hypernatremia. Similarly, problems in sodium regulation cause changes in volume. Water changes is volume, right? For example, if aldosterone is or mineralocorticoids are more, what happens? More of sodium is absorbed, hence more of water is absorbed. There will be hypervolemia and hypertension. Example of this is Conn syndrome or Liddle syndrome, etc. When aldosterone is low, like in Addison's disease, there will be hypovolemia, right? Hypotension and hypovolemia. So this you would have discussed in physiology, but I am just mentioning it here to make you understand it easier. So two regulations occur in the collecting duct. One is sodium regulation, which happens through mineralocorticoid receptor, water regulation, which happens through ADH. Problems with sodium regulation cause changes in water. Problems in water regulations leads to changes in sodium. So this is just a point to mention that the entire loop of Henle and the cortical collecting duct. So the loop of Henle through its sodium potassium 2 chloride channel and the collecting duct through its aquaporin 4 mechanism leads to concentration of urine. So in CKD, this concentration of urine gets affected. When concentration of urine gets affected, we get a finding called as isosthenuria. Isosthenuria is the urine specific gravity will always be fixed, 1.010. It's not dilute, it is not concentrated. So I took some time to discuss about this basic because if you understand that, understanding this table is very, very easy. Okay, so tubular diseases, I told you tubular or interstitial diseases. Usually they are taken together. So here they are given acute tubulointerstitial disease. So which are the conditions where acute tubulointerstitial diseases can occur? So one, antibiotics, some drugs. So many drugs can cause nephritis. Infections can cause nephritis. So this we had discussed already in AKI. Now some autoimmune diseases also can occur, like Sjogren syndrome, SLE, this can occur. So drugs, infection, and autoimmune diseases. This can cause it. Now see the last one. Tubule is like nothing but a tube, so anything can deposit there. Myeloma kidney, acute phosphate nephropathy, urate nephropathy, that is hemolysis, myoglobinuria. It's also an acute tubular disease. This also we had discussed in the initial table. Now when diseases become chronic, we have some chronic tubulointerstitial diseases. So one is vesicoureteric reflex or reflex nephropathy. I was telling you the entire tubular system ends with the collecting duct. Collecting duct forms the renal collecting system and it enters the renal pelvis. So whenever there is a obstruction by reflex, it will affect the kidney also. So one of the most common cause of chronic tubulointerstitial disease will be chronic obstructive diseases like vesicoureteric reflex. Then we have other diseases also. Again, chronic drug-induced lithium, heavy metals. So most of these will be drugs. So drugs and vesicoureteric reflex or reflex nephropathy, these are the chronic tubulointerstitial diseases. And some deposition diseases like calcium, nephrocalcinosis, hyperuricemia, hyperoxaluria, cystinosis, these deposition diseases affect the tubules. And cystic diseases, there are 4 cystic diseases of the kidney: polycystic kidney disease, nephronophthisis, medullary cystic kidney, and medullary sponge kidney. These 4 cystic diseases are also tubulointerstitial diseases. We'll leave off the last one. So apart from this acute tubulointerstitial nephritis or chronic tubulointerstitial nephritis or deposition diseases or cystic diseases, the 4 categories which we discussed, the channelopathies can also occur without any other renal disease. So example for channelopathies are renal tubular acidosis, right? There is acidosis and electrolyte imbalance without affecting the renal function. Then we discussed about the Gentleman, Barter, and Liddle syndrome. Right? So channelopathies. So tubular diseases can be pure channelopathies. It can be acute interstitial nephritis in the form of drugs, infections, autoimmune diseases, or obstruction. Chronic tubulointerstitial disease can be vesicoureteric reflex or by drugs. And again, it could be due to deposition like oxalate crystals or hyperuricemia. And we have 4 separate cystic diseases of the kidney. Okay. So this is just a small slide showing acute interstitial nephritis. We will not discuss this much. So these are the channelopathies which I was telling you. So whenever you think of renal diseases, you should learn about the channelopathies also. See, proximal tubule, there are so many diseases because most of the ions are reabsorbed in the proximal tubule. So when proximal tubule is problematic, we get many diseases. Remember Fanconi syndrome. Remember proximal renal tubular acidosis or type 2 renal tubular acidosis. Remember cystinuria. Cystine is a protein which is not getting reabsorbed here. Renal glycosuria. When blood sugar is more than 180, there will be glycosuria. But even without elevated RBS, there can be glycosuria. That's called as isolated renal glycosuria. Then Hartnupp's disease. Okay, dense disease. So remember few of these diseases. Now, what disease involves loop of Henle? We just now discussed about Bartter syndrome. Bartter syndrome is similar to loop diuretics or furosemide, boyfriend. Here, sodium is excreted, potassium is excreted, magnesium is excreted, but calcium is not. Calcium is also excreted. Then, what disease affects the distal tubule? One is Gentleman syndrome, Liddle syndrome, which we discussed. Then nephrogenic diabetes insipidus, because antidiuretic hormone acts on the vasopressin receptor type 2 to cause aquaporin 4 expression and water reabsorption. When there is a problem in this mechanism in the kidney level, it causes nephrogenic diabetes insipidus. Central diabetes insipidus is ADH is not produced by the brain, pituitary itself. But ADH is produced, it is not acting in the kidney, it is called nephrogenic diabetes insipidus. Then think about distal RTA. Okay, so these are the diseases, channelopathies affecting the kidney. So that is about channelopathies. Then coming to cystic diseases. So there are 4 cystic diseases I told you. Nephronophthisis, polycystic kidney disease, medullary sponge kidney, and medullary cystic kidney. So in that AD polycystic kidney disease common. We have 2 types of polycystic kidney disease. One is autosomal recessive polycystic kidney disease and autosomal dominant polycystic kidney disease. Autosomal dominant polycystic kidney disease occurs in adults. Even though it is a genetic disease or a congenital disease, it presents in adulthood. So they will be normal in childhood, they present only in adulthood. Whereas autosomal recessive polycystic kidney disease occurs in pediatrics, it's an infant disease. Autosomal recessive polycystic kidney disease is severe because it occurs in childhood. ADPKD, okay, it is mild to moderate. But both finally lead to end-organ kidney disease, that is chronic kidney disease, end-organ renal disease, and may need transplant or HD. So the incidence they have given, what is the gene involved? In autosomal recessive polycystic kidney disease, it is PKHD1 in chromosome 6, try to remember this. In ADPKD, 2 genes are involved, PKD1 in chromosome 16 or PKD2 in chromosome 4. PKD1 normally produces a protein called as polycystin 1 that is deficient. PKD2 in chromosome 4 produces polycystin 2. So these proteins are deficient. In ARPKD, PKHD1 is normally produces fibrocystin 1 that is deficient. So both causes cystic diseases. So there will be diffuse cyst in ARPKD, there will be haphazard cyst in ADPKD. One important feature is ADPKD is associated with berry aneurysm. So there can be subarachnoid hemorrhage when this berry aneurysm ruptures. This is a very important association. So ADPKD occurs in adults due to mutation PKD1 and PKD2. There can be features of SAH. Presence with renal failure in adults, there can be hypertension. So medically can be treated with tolvaptan. Why tolvaptan? Tolvaptan is a ADH receptor antagonist, right? Because pathophysiologically, the distal convoluted tubule only gets affected here. So when we are inhibiting this receptor, we can prevent the cyst formation. So tolvaptan is the treatment here. But even though if they end up in renal failure, finally it may need HD or transplant. ARPKD, problem is with PKHD1 gene, usually occurs in infancy, it causes fetal death usually. So this is the important cystic disease. So this is about vesicoureteric reflex. This is a image of micturating cystourethrogram. So this will be discussed in surgery only. So what happens is, normally when we void, the ureter should get completely empty. The bladder will contract and it will empty into the urethra. None of the urine from the urinary bladder will go back into the ureter. But see, this is the bladder. When the child is voiding, normally urine should go only through the urethra. Nothing should enter the ureter. But here, from the urinary bladder, urine is going back into the ureter and it is causing dilation. So this is called vesico. Vesico is urinary bladder ureteric reflux. So why vesicoureteric reflux is important from a medicine perspective is, chronic vesicoureteric reflux will also dilate the collecting duct. When collecting duct is dilated, what happens? I told you it can lead to renal tubular acidosis, it can lead to electrolyte imbalance, it can lead to anemia, okay, it can lead to calcium and phosphate homeostatic problems, because the entire entire tubule system is also affected. So this is one cause. Vesicoureteric reflex is one cause of tubulointerstitial disease. So revising tubulointerstitial diseases, the causes: one, there can be acute tubulointerstitial nephritis. This presents as acute kidney injury. So causes are usually drugs or infections or autoimmune or deposition of crystals or casts like myeloma kidney or rhabdomyolysis or uric acid nephropathy. Then we have chronic tubulointerstitial nephritis. In that we have vesicoureteric reflex or reflex nephropathy. Again, chronic drug use. Then we have deposition disease like oxalate crystals, cystinuria, etc. Then the third tubulointerstitial disease will be cystic diseases of kidney. We discussed ADPKD and ARPKD. Then the fourth will be pure channelopathies. Okay. So this is about nephrology. Now we will discuss shortly about electrolytes and fluids. We will discuss few sodium and potassium disorders and about fluids. So I already told you the collecting tubules are very important, because collecting tubules only maintain the sodium balance. They also maintain water balance. If there is a problem with the sodium balance, it leads to volume changes. For example, if there is aldosterone excess or ENaC activation, there will be hypervolemia or hypertension. Example is Conn syndrome. Suppose there is aldosterone deficiency. Example in Addison's disease, there will be hypovolemia and hypotension. Similarly, if there is a problem with water balance is mediated by antidiuretic hormone acting on V2 receptor in the collecting tubule, activating aquaporin 4 and causing water reabsorption. If there is a problem with water problem, it will lead to sodium changes. So example will be, if there is excess antidiuretic hormone, it is called syndrome of inappropriate excess antidiuretic hormone. It leads to hyponatremia, because excess water is reabsorbed, there will be volume dilution in the blood leading to hyponatremia. On the contrary, if there is low ADH or there is low ADH action, that is if there is a central diabetes insipidus or a nephrogenic diabetes insipidus, water is excreted more, so blood becomes concentrated and it leads to hypernatremia. With this gist, we'll just discuss hyponatremia. We'll not discuss it very detailed, we'll just discuss shortly. Always in electrolyte imbalances, be it hyponatremia or hypernatremia, hypokalemia or hyperkalemia, always try to find out whether it is true hyponatremia or true electrolyte abnormality. Because example is, if the patient is having uncontrolled diabetes, if the patient is having hyperglycemia, or if the patient was given an osmotically active substance like mannitol, we'll get a falsely low sodium, right? That is called as pseudo-hyponatremia. So once pseudo-hyponatremia is ruled out, that is, there is no hyperglycemia, there is no hyperuricemia, only then we can tell that it is true hyponatremia. True hyponatremia is called as hypotonic hyponatremia, because the osmolality of the blood reduces in hyponatremia. So that is hypotonic hyponatremia. Always in hyponatremia, look at the volume status. So hyponatremia can be classified as hypovolemic hyponatremia, euvolemic hyponatremia, hypervolemic hyponatremia. Hypovolemic hyponatremia is easy to remember because patient is hypovolemic. So what are the causes here? Vomiting, diarrhea, burns, pancreatitis, or diuretic loss. Even if you don't remember this evaluation, it is not an issue, but it is easy to remember only. When there is hypovolemia, I told you the body tries to conserve electrolytes, conserve water. So when there is a extra renal loss like a vomiting or diarrhea, kidney will conserve sodium. So what will happen to the urine sodium? Urine sodium will be less. But if the loss happens from the kidney itself, like by giving a diuretic, urine sodium will be high. Now come to the right side of the column. Hyponatremia with hypervolemia. So here the water also increases, sodium also increases, but water becomes more, water absorption becomes more than sodium absorption. So there will be hyponatremia. This occurs in renal failure, nephrotic syndrome, or heart failure. So there's a hypervolemic condition which dilutes the sodium, causing hypervolemic hyponatremia. Now the middle one, euvolemic hyponatremia, is the classic SIADH which we discussed. So there are only 4 causes of euvolemic hyponatremia. The most important cause among them is SIADH. Even if you don't remember others, it's not an issue. SIADH causes euvolemic hyponatremia. Other causes are glucocorticoid deficiency, that is Addison's, hypothyroidism, stress, and drugs. So if you see the causes of SDH, practically any condition can cause SIADH. I will tell like this: any lung disease can cause SIADH. Any CNS disease can cause SIADH. Drugs, mainly antipsychotics, any drug acting on the brain, any drug acting on the mind will usually cause SIADH. Plus any cancer can cause. So any cancer, any lung disease, any brain disease, and any drug can cause SIADH. So SIADH is a problem of water balance causing hyponatremia. Now we may discuss 3% saline is a fluid. Usually the normal saline which we tell is 0.9% sodium chloride. So why we are discussing about the fluids is, how will you treat hyponatremia? If there is a hypovolemic hyponatremia, we have to give fluids and correct the hypovolemia. If there is a hypervolemic hyponatremia, we have to give diuretics to remove the excess volume. If there is euvolemic hyponatremia, 2 things. One, it's a problem with water balance, right? So you have to reduce water intake. So reduce water intake. Suppose if still it is not there, we have to give tolvaptan, or we have other vaptans, conivaptan. These are the ADH receptor antagonist. Remember, tolvaptan is the drug of choice for autosomal dominant polycystic kidney disease. Tolvaptan can also be used in SIADH. But what is the fluid choice now? Because we usually discuss 2 fluids. Our normal saline, the so-called normal saline, is 0.9% sodium chloride. It has 154 milliequivalents of sodium and 154 milliequivalents of chloride. 3% saline, on the contrary, has 518 milliequivalents of sodium and 518 milliequivalents of chloride. So 3% saline has more of sodium. So when there is hyponatremia, we will be more intended to give this 3% saline. But remember, there are only few indications for 3% saline. One, severe hyponatremia. When do you say hyponatremia is severe? When sodium is less than 120 milliequivalents per liter. Remember, the normal sodium is 136 to 146 milliequivalents per liter. When sodium is less than 136, we call it as hyponatremia. When sodium is more than 146 milliequivalents per liter, we call it as hypernatremia. When sodium is less than 120 milliequivalents per liter, it is called as severe hyponatremia. Then we give 3% saline when there is symptomatic hyponatremia. For example, there is a seizure, when there is coma. In that case, we have to give 3% saline. So these may be framed as questions or scenarios. So decide on the best treatment. In that case, if there is a severe hyponatremia, we have to give 3% saline. If there is a symptomatic hyponatremia, we have to give 3% saline. Okay. Right. In other cases, we have to treat the cause, either fluids or diuretics or water restriction. So, and the third indication for giving 3% saline is acute hyponatremia. There is hyponatremia occurring suddenly. So, which are the conditions causing acute hyponatremia? One is important causes I'll tell you. One is glycine irrigation. So, usually in doing TERP or uterine surgery or hysteroscopy, to visualize the uterus, they usually instill a fluid which is called glycine. When it gets absorbed, that is called post-hysteroscopy fluid absorption syndrome. This fluid is low in sodium. So when this fluid gets absorbed into the blood, it will dilute the blood, leading to acute hyponatremia. So a colonoscopy preparation or glycine irrigation in TERP or uterine surgery, or we are instilling hyponatremia by wrongly giving a hypotonic fluids. Which are hypotonic fluids? Dextrose containing fluids like 5% dextrose or 25% dextrose are called hypotonic fluids. Why they are called as hypotonic fluids? Because assume that we are giving this fluid in the blood. This blood will enter the vascular compartment. When this is given in the vascular compartment, the glucose is taken up by the cells, taken up by the RBCs, WBCs. So whatever is there, glucose is completely utilized. So what remains is there is only pure water. Now we have this scenario. The intravascular volume is diluted by this free water, so it becomes hypoosmolar. What happens to the intracellular compartment? The ICF. Now the ICF is normoosmolar. So we know that the process of osmosis happens. Osmosis is movement of solvent. Solvent is nothing but water. Movement of water from region of low concentration to region of high concentration. This is called osmosis through a semi-permeable membrane. The plasma membrane is a semi-permeable membrane. So when the plasma becomes diluted with this 5% dextrose or 25% dextrose, intravascular volume becomes hypoosmolar. So osmosis happens, that is water moves from intravascular to the intracellular compartment. So the ICF swells or the cells swell. This is what happens in hyponatremia. So I told you, example in hyponatremia, the same thing happens. Intravascular volume becomes hypoosmolar, so the cells swell. Example, brain swell. So it leads to cerebral edema. That is why hyponatremia is very dreaded. So same thing when we are giving 5% dextrose or a hypotonic fluid, there will be loss of fluid from the intravascular volume to the cell, which is not needed. So suppose if the patient is in shock, we must not give hypotonic fluids. Okay. So giving hypotonic fluid will lead to hyponatremia, and glycine irrigation is also a hypotonic fluid. Colonoscopy preparation, then recent intake of thiazide diuretic, then excess water intake. Polydipsia is excess water intake. Then excess induced because of excess sweating, and MDMA, ecstasy injection. So these are the acute causes of hyponatremia where we must give 3% saline, and severe hyponatremia or symptomatic hyponatremia we must give 3% saline. Now we know very well that hyponatremia must be corrected slowly. Whatever it is, hyponatremia or even hypernatremia must be corrected slowly. We'll discuss why. So already I told you, when there is hyponatremia in the intravascular volume, brain cells swell. So brain cells are already swollen. because of osmosis. The water from the intravascular volume moves into the brain cells, causing cerebral edema. Now when the cerebral edema is very chronic, like for more than 48 hours, what happens is the brain will try to adjust its own by reducing the production of osmolytes. So the plasma is hypoosmolar, the brain was normoosmolar. So now after 2 days there is some sort of balance, because when the fluid goes inside, both have an equal osmolality, and to maintain osmolality the brain reduces production of osmolytes. The brain also has some osmolar substances, so to compensate for hyponatremia outside, the brain decreases production of osmolytes. So after 2 days the brain has low osmolytes, and outside there is low sodium. Now when we correct the sodium rapidly, what happens when sodium suddenly increases, there will be an imbalance here. Again, now the brain cells are hypoosmolar, the blood becomes hyperosmolar, plasma becomes hyperosmolar. So osmosis happens in the reverse direction. Water moves from the brain cells to the plasma, shrinking the brain, causing myelinolysis. This is called osmotic pontine demyelination. This leads to a dreaded complication. This is a dreaded complication where patients can go for paralysis, paraparesis. So following rapid correction of sodium, due to the imbalance in the production of osmolytes, they can go for osmotic demyelination. So sodium must be corrected slowly at the rate of 10 to 12 millimoles per day, or milliequivalents per day. Right. So while discussing sodium itself, we discuss something about fluids. Likewise, we have hypernatremia. Hypernatremia also has 3 causes. We have hypovolemic hypernatremia. Why hypovolemic hypernatremia? Patients do not consume water. So occurs in very old age patients who do not drink water. So how will you treat this? Giving water. Right? When water is deficient, hypernatremia occurs. Then we have hypervolemic hypernatremia. How come hypernatremia and hypervolemia occurs in salt toxicity? Patients take more of salt, or we give more of normal saline. So this is treated with diuretics. Right? So hypovolemic hypernatremia occurs in old age because of reduced water intake. Hypervolemic hypernatremia occurs because of salt toxicity. Now what about euvolemic hypernatremia? We know the classic diabetes insipidus. Diabetes insipidus can be cerebral diabetes insipidus or central DI, nephrogenic DI. Central DI, we give desmopressin. Nephrogenic DI, we have some drugs. We can give thiazides, we can give NSAIDs. But what is the emergency management? We have to replace water, right? So it is free water replacement. In this case, what fluid can we prefer? We can give 5% dextrose, right? Because 5% dextrose is a hypoosmolar fluid, correct? 5% dextrose is a hypoosmolar fluid, so it is equivalent to giving water. So that is preferred. Here also we have to correct slowly in the rate of 8 to 10 or 10 to 12 milliosmoles per day. So why so? Here the opposite phenomenon happens. What happens when there is hypernatremia in the blood? The brain cells are already shrunken because of osmosis. ICF, water moves from ICF to the plasma due to osmosis. This is normal, occurs in hypernatremia. When you suddenly lower sodium, and in compensation to this, what happens? Brain increases production of its osmolytes to retain water. So in chronic hypernatremia, brain will have increased osmolytes. When you suddenly lower the plasma sodium, brain has more of osmolytes, the blood sodium is low. So now osmosis will happen in the reverse direction. So ICF will swell, brain will swell, so we will have cerebral edema. So that is why in chronic hyponatremia we should correct sodium slowly to prevent osmotic demyelination. In chronic hypernatremia we should correct sodium slowly to prevent cerebral edema. This finishes sodium. Now quickly going to potassium. You know, potassium is closely linked to aldosterone. Okay. The function of aldosterone is to stimulate ENaC. So when aldosterone is there, sodium increases in the blood, potassium is excreted, so it causes hypokalemia and it causes alkalosis. Right? So as I already told you, whenever there is hypokalemia, the first step is to prove that there is pseudo-hypokalemia. If it is pseudo-hypokalemia, if pseudo-hypokalemia is ruled out, then it is true hypokalemia. Always think in potassium, there are three possibilities. One, there can be reduced intake of potassium. Second, there can be shift of potassium, because potassium is a major intracellular ion. What potassium is present in the blood, that is 3.5 to 5 milliequivalents per liter, is only a very low amount, whereas intracellular fluid has large amounts of potassium. So whenever potassium levels change in the blood, actually it buffers with the intracellular compartment. So when potassium is low, it actually means some amount of potassium may have been shifted into the ICF. Example is by giving insulin. Insulin shifts potassium into the cells. So patients getting insulin may have hypokalemia. Patients having alkalosis may have the shift. So we have to look for these shift conditions. Okay, that is what is given. If there is a transcellular shift like insulin excess, beta agonists like salbutamol, hyperthyroidism, so these conditions should be ruled out. Then the third is there is reduced renal excretion. So there is increased renal excretion, or there is increased non-renal excretion. Okay, that is what the other causes. So if pseudo-hypokalemia is ruled out, if transcellular shift is ruled out, then some loss is there. Don't think about this TTKG etc. They are very complicated. But just remember, if high aldosterone can cause potassium excretion and renal loss, right? So these are the conditions: Liddle syndrome, Cushing syndrome, renal artery stenosis. Then think of the other conditions: loop diuretics, thiazide diuretics, Bartter Gentleman. So these are the renal conditions. So either we are giving a diuretic to excrete potassium, or we are increasing the amount of aldosterone, like in Conn syndrome, or primary hyperaldosteronism, or Liddle syndrome, or Cushing syndrome. All these conditions, aldosterone will be high. So all these conditions are causing potassium excess, and there can be non-renal loss, like GI loss, like diarrhea. Okay. So look for pseudo-hypokalemia, look for reduced intake, look for shift of potassium, look for renal loss, look for non-renal loss. Renal loss will be aldosterone excess, Bartter syndrome, Gentleman syndrome. Same thing holds good for hyperkalemia. Always rule out pseudo-hyperkalemia. Okay. When pseudo-hyperkalemia is ruled out, look for shift, or look for increased intake. Then look for shift. So the opposite of the other conditions. So hyperglycemia will have, or in DKA, when there will be insulin deficiency, hyperkalemia can occur. Some drugs like digoxin, beta blockers. Why beta blockers? Beta sympathetic stimulation, the first step in RAS, renin-angiotensin system. So these conditions cause transcellular shift, or there can be reduced renal excretion, or aldosterone deficiency, right? So giving aldosterone antagonist like spironolactone, that is one cause. Then some other drugs can cause hyperkalemia. Okay, so mainly it is drug-induced, aldosterone antagonist, adrenal insufficiency. So adrenal insufficiency will cause hyponatremia and hyperkalemia. I think you can understand why it is so now. Okay, so Conn syndrome or aldosterone excess will cause hypernatremia and hypokalemia. Aldosterone deficiency will cause hyponatremia and hyperkalemia. Okay, so these are the cause of hyperkalemia. Both hypokalemia and hyperkalemia are emergencies. So the cause evaluation comes next. So how will you treat hypokalemia? Supplement potassium. Either oral supplementation or IV supplementation. How will you treat hyperkalemia? First step is by giving calcium gluconate. This calcium gluconate does not correct the hyperkalemia. It stabilizes the membrane, because the main problem with hyperkalemia is that if it affects the heart. Like sodium is affecting the brain, hyperkalemia affects the heart. Especially when potassium is more than 6.5, it leads to ECG changes like tall T wave, prolonged QRS. It occurs in steps. First tall T waves occur, then prolonged QRS, then prolonged QT. Then it can even lead to ventricular tachycardia. So it leads to arrhythmias, please remember. That's why we have to give calcium gluconate to stabilize the cardiac membrane to prevent arrhythmias. Next, we want the potassium to be shifted. So what you can give? You can give insulin. When insulin is given, there will be hypoglycemia. To prevent hypoglycemia, we give 25% dextrose. So 25% dextrose plus 10 to 15 units of insulin. Third, we can give bicarbonate. Sodium bicarbonate is causing alkalosis. Alkalosis will shift the potassium into the cells. Then we are excreting the excess potassium by giving potassium binding resins. Okay, so first step is to stabilize the membrane. Next is to shift the potassium. Third is treating the cause. Now coming to the last part of today. Fluids can be classified as colloids and crystalloids. Colloids is the human albumin, hemaxyl, etc. Usually they say don't prefer colloids nowadays. Only in few specific situations they are used. Crystalloids are the best fluids. The normal fluids which we used is crystalloids. So in that we discussed normal saline already. It has 154 milliequivalents of sodium and 154 milliequivalents of chloride. So total we have 308 milliequivalents. So it is an isotonic fluid. Okay, because it has sodium, it does not have glucose. Any glucose containing fluid has the chance of becoming isotonic. So it is given to expand volume. So whenever there is a vomiting, diarrhea, etc., we give. And especially normal saline is given when there is vomiting. Why it is given in vomiting? In vomiting, hydrochloric acid is lost. When hydrochloric acid is lost, there is loss of chloride. I told you, normal saline has more of chloride. So we can give sodium chloride. So it is preferred in vomiting. When excess normal saline is given, chloride buffers with the bicarbonate. So when chloride increases, bicarbonate reduces, leading to acidosis. So the fluid which causes acidosis when given in large amounts is normal saline. This was a question asked in one of our competitive exams. Now another isotonic fluid is Ringer's lactate. Ringer's lactate has 130 milliequivalents of sodium, 4 milliequivalents of potassium, 109 milliequivalents of chloride, 3 milliequivalents of calcium and 28 milliequivalents of lactate. Total osmolality is 273. Now this is more physiological, right? Because normal saline had 154 milliequivalents of sodium, whereas the normal serum level is only 136 to 146 milliequivalents. Whereas Ringer lactate has only 130 milliequivalents. It is close to the plasma level. It also has potassium and chloride. Potassium and calcium. Chloride is also in the lower limit. And excess lactate gets converted to bicarbonate in the body when the liver is normal. Okay, that is why This Ringer's lactate should not be given if there is a liver disease, because liver only converts lactate to bicarbonate. When liver is diseased, this Ringer lactate cannot be converted to bicarbonate, so it will lead to acidosis. So never give oral if there is a liver cirrhosis. And like NS, this is also used to volume expand. It is given in emergency. It is preferred in diarrhea, because diarrhea, not only chloride is lost, here all the electrolytes like potassium, calcium, etc. is lost, and diarrhea causes acidosis. But oral causes alkalosis. That's why in these conditions we prefer Ringer's lactate. So the fluid which causes alkalosis is oral. The fluid which causes acidosis is normal saline. Then we discussed about 5% dextrose. 5% dextrose is, it has 5 grams in 100 ml of fluid, or 50 grams in 1000 ml of fluid, right? It has only glucose. When this is given in the plasma, it is initially isotonic, but this glucose is taken up by the cells, so it later becomes hypotonic. So it does not expand. It should not be given to expand ICF. Okay, it should not be used for fluid resuscitation. It should be given only when patients cannot take fluids, cannot take oral intake, to treat hypoglycemia. It is given especially in post-surgical NPO patients when their BP is normal, because they can't give take fluids, right? Similarly is 25% dextrose. 25% dextrose is 25 grams of glucose in 100 ml. So it comes as 100 ml bottles. It has 25 grams. If you see, if you compare it with 5% dextrose, a 500 ml bottle of 5% dextrose also has 25 grams of glucose. A 100 ml bottle of 25% dextrose also has 25 grams glucose. But this 25% dextrose is given in emergency conditions having hypoglycemia. Why? Because small volume can be given faster, so it can treat. So in hypoglycemia, we give 25% dextrose. So I think you will remember the Whipple's triad of hypoglycemia. The triad is 1. There are symptoms of hypoglycemia. Second condition for Whipple's triad is there should be documented hypoglycemia. Third point is the symptom should reverse on giving glucose, right? So the third point is on giving 25% dextrose. So these are the hypotonic fluids. 25% dextrose and 5% dextrose are the hypotonic fluids. Initially there was something called as Ringer's lactate, but Ringer's fluid, it will have the same thing like Ringer's lactate, but lactate will not be present. It's not common nowadays. Then we have some other fluids like isolate. These are also isotonic fluids. Isolate M, isolate G, isolate M, isolate E. Even if you don't remember the composition, just remember the uses. M is for maintenance. Isolate M is can be used as a maintenance fluid. It can be used in diarrhea. This isolate M has the highest potassium content. Isolate M has the highest potassium content. Isolate G. G is the gastric replacement solution. So where gastric replacement is done? When there is vomiting or when Ryle's tube aspiration is more. So when there is vomiting or when Ryle's tube aspiration is more, we give isolate G. So G means definitely chloride should be present there, right? So the highest chloride is present in isolate G. So if already chloride is high, we should not give isolate G. Isolate P. Isolate P is the pediatric maintenance fluid. So it is also given in diarrhea for children. So which are the IV fluids which are given in diarrhea? oral, isolate M, and in pediatrics you can give isolate P. Oral is given initially to volume expand. So if there is hypovolemia, we can give it for, initially we give oral, and isolate M is given as the maintenance. Okay. Isolate E has the high magnesium content. So these are the other isotonic fluids. So this completes our entire nephrology and fluids